Hi, so we are going over the cardiac system. Cardiac system structures. Key structures of the cardiovascular system and their functions. The heart, a continuous pump that does not stop and is constantly working through the internal and external demands from the body, such as exercise, stress, and sickness. Each side has a ventricle and an atrium, so like the left atrium and ventricle and the right atrium and ventricle. Blood pumps into the heart, to the lungs, and then back through the heart and spreads through the body. Arteries, the blood vessels that carry oxygenated blood cells through the body to their destinations, oxygenating the body in turn. They also distribute hormones and nutrients throughout the body and help keep blood pressure steady. Capillaries. According to the National Cancer Institute, capillaries, the smallest and most numerous of the blood vessels, form the connections between the vessels that carry the blood away from the heart, arteries, and the vessels that return the blood to the heart, veins. The primary function of the capillaries is the exchange of materials between the blood and tissue cells. And then over here to the right is a little diagram that I thought was good to look at. Veins carry deoxygenated blood back to the heart so they can restart the cycle. Blood flow through the heart and periphery. Blood flow through diastole, aka ventricular relaxation. Ventricles relax, allowing oxygenated blood in the left atrium to flow down into the left ventricle, and deoxygenated blood from the right atrium to flow down into the right ventricle. Blood flow throughout through systole, aka ventricular contraction. Ventricle muscles contract, pushing deoxygenated blood from the right ventricle into the lungs via the pulmonary artery to be oxygenated, and oxygenated blood from the left ventricle out into the body via the aorta. Cardiac cycle. Over here is a diagram to the right. I thought that was a good visual just to follow along with it. It was easier for me to learn that way anyway. Deoxygenated blood flows into the right atrium via the superior and the inferior vena cava. When the heart is in diastole, that deoxygenated blood flows down into the right ventricle via the tricuspid valve. When the heart goes into systole, the blood is pushed through the pulmonary valve into the pulmonary artery and into the lungs, where gas exchange occurs at the capillaries, and blood cells pick up oxygen. When diastole occurs again, the blood is taken into the left atrium via the pulmonary vein and then to the left ventricle via the mitral valve. When systole happens again, that now oxygenated blood is pumped out into the body through the aortic valve and out through the aorta, where it is carried through the various arteries in the body to their specific designations or destinations. Left versus right-sided heart failure. So left-sided heart failure, it is caused by the resistance of blood due to aortic stenosis or hypertension when the valve can no longer contract properly, plus weakening of the left ventricular contraction due to an MI when the death of myocardial cells causes an ineffective contraction. Blood flows back into the organs, causing fluid buildup in the lungs and or other body parts, and body parts not getting adequate oxygenation. So signs and symptoms that you're going to be looking for with somebody with left-sided heart failure would be constant coughing, shortness of breath when walking or bending over. They can't sleep on their back because of the fluid buildup in their chest, so it's hard for them to breathe, so they have to sit with their head elevated or sleep with their head elevated. Displaced apical pulse, acute phase. During this time, there is usually bilateral crackles in the pulmonary edema due to pulmonary edema. Right-sided heart failure, caused by hypertrophy of the ventricle and pulmonary hypertension, or necrosis from a myocardial infarction. Failure of right ventricular pumping is a backflow of blood back into the body. So instead of like the left-sided heart failure where the blood and fluid buildup is in the chest and lungs, this on the right side, it will be in the peripheral body parts. So like the most common place is the legs. That's where you're going to see it the most. Um, so other signs and symptoms would be the S3 heart sound at the lower left sternal border, chest pains, breathlessness, and heart palpitations. Accurate placement of stethoscope. Palpate for right sternal.
So today we're going to be listening to the heart points on the body.
Sorry. So you're gonna look for the 5 points. That is the aortic, the pulmonic, the Erb's point, tricuspid, and mitral valve. For the aortic point, you're going to palpate for the right sternoclavicular point, palpate the first rib, then palpate the space between the first and the second rib. This is the first intercostal space. Move down one more intercostal space to the second right intercostal space. Next to the sternal border, this is the space on the chest where the aortic valve can be heard the best. So this is the aortic point. From here, you will move to the left side, and you're gonna mirror what you did on the right side. So on the left side, second intercostal space next to the sternal border, this is the area to auscultate the pulmonary valve or the pulmonic point. Down to the third, for the third one, you're gonna move down to the third left intercostal on the left sternal border. This is called Erb's point. Pulmonary and aortic sounds are frequently radiated here. And then for the fourth one, you're going to move down to the left intercostal space on the sternal border, and this is the tricuspid valve area. So for the last one, you're going to move down to the fifth left intercostal space, and then move your stethoscope to the left midclavicular line to find the mitral valve area. And here's the video.
So today we're going to be listening to the heart points on the body. So that would be the aortic, pulmonic, Erb's point, tricuspid, and the mitral. You want to use the diaphragm for the higher pitch and the bell for the lower pitch. Alright, so this might be a little cold.
Why does it keep doing that?
Okay. So and what you're listening for is the S1 and S2 sounds, or the lub dub. You might hear some S3 or 4 sounds, or galloping, which can be normal in younger children. And for all of this, I would come in, introduce myself, and wash my hands. Thank you.
Alrighty. So causes and how to assess for heart murmurs. So causes for heart murmurs, they're caused when there's a turbulent and rapid blood flow to the heart. There are innocent heart murmurs that are common in newborns and infants, and worrisome heart murmurs that are caused by heart defects in children and adults. So in children, those defects will be holes in the heart and cardiac shunts. And then for adults, those defects would be calcium deposits, rheumatic fever, and endocarditis. So, some ways to listen to the heart murmurs. Here's some heart murmurs to listen for and how to find them. A normal heart sound is an S1 systole and S2 sound diastole. When there's a sound before S1 or after 2, this is called a murmur or a gallop. Aortic valve stenosis. Use the bell over the aortic valve area. There will be a medium pitch at the second right intercostal space, and a low pitch radiates down the left sternal border. With pulmonic valve stenosis, use the bell over the pulmonic valve. There's a medium pitch thrill in the second and third intercostal space. Here's some more. So for the aortic valve regurgitation, with the patient sitting and leaning forward, use the diaphragm over the second right intercostal space. A blowing sound in early diastole will be heard radiating over the left sternal border. Pulmonic valve regurgitation. With the patient leaning forward, use the diaphragm over the third and fourth left intercostal space, a higher low-pitched blowing sound will be heard. Mitral valve stenosis. Use the bell at the apex. With the patient on the left side, a low-pitched rumble will be heard. And then, more intensely in early and late stage diastole. With tricuspid valve stenosis, use the bell over the tricuspid area, a low-pitched rumble will be heard. Mitral valve regurgitation. Use the diaphragm at the apex. A high-pitched, harsh blowing will be heard radiating left of the axilla or base. Tricuspid valve regurgitation. Use the diaphragm at the fifth left intercostal space. At the fifth left intercostal space, left lower sternal border, a high-pitched blowing will be heard. And then this is my examination.
Hi. So we are going to assess the cardiac system today. I come in, knock, do hand hygiene, introduce myself. Hi, I'm Jessica, I'm your nurse today. And then I do 2 patient identifiers. What's your name and date of birth? His name's Matthias, and his birthday is in June. Okay, so the first thing I would do is I would inspect his skin appearance. He seems to be doing okay. There's no obvious abrasions. He seems to be pink, and his breathing is unlabored. No retractions. And then I would palpate for an apical pulse, which is going to be over here in the 4th and 5th intercostal. Found that. Good. Okay. We're going to sit there, we're going to count it. All right. And then we are going to listen. We're going to auscultate it in the same area. And note that there is an even heart tone of S1, S2. There are no gallops. Even rhythm. All right. And then I would calculate the pulse deficit, which is the apical minus the radial. Take the radial pulse. Really set strong. All right. Doing okay? All right. I need you to sit straight, please. Alrighty. And then I already listened for the heart sounds, the pulse deficit. Okay, so I'm going to palpate the temporal. Okay, those are even. And then I'm going to palpate for the carotid only on one side because we don't want our person passing out. I think that's present. Okay, so then we would, I need you to sit straight, please. Inspect the jugular, make sure that there's no jugular distension, and then we would check their blood pressure. Alrighty, so I'm going to inspect the upper extremities. Again, everything looks good. Skin looks good. There's no purpling. We're going to check capillaries. It is well within less than 2 seconds. And the nail beds are curved. There's no cutting or anything. The skin is pink. Looks well oxygenated. We are going to do your brachial. So that's in here. Found that. And then again, we'll do the radial. That's there. Make sure it's on both sides. Can you check in your arm? Yeah? Alright. Let's see here. Then we're going to start moving to the lower extremities. Make sure everything is good. There's no distended veins. Make sure nothing's purple. Why? Because that means oxygen is going to everywhere it's supposed to, bud. Alright, and then we are going to look for the popliteal. And femoral. So there's one in here. And then just sit still, please. Okay. Popliteal's back here. Okay. Check for the one down here. That one's nice and strong, bud. And then you're gonna check up here. This one's the dorsalis pedis. Okay, check the nail beds again. They're pink. Capillary refill is within 2 seconds, and there is no edema. Hair is even. So it would appear that our patient is doing well. Thank you.
All right, and then these are the works cited that I did. And then thank you.